Good evening, all. Thank you so much for joining us this evening. I'm joined by Professor Papanikolaou from Assisting Nature in Greece. They have multiple locations there, discussing the very important topic of multiple IVF failures. What next? I see this so frequently with clients, so I know you're going to enjoy this conversation as we dive deep into this topic. There's a lot of questions around a lot of different areas, so bear with us. And of course, we'll be getting to questions at the end. Just to give a bit of an introduction to Professor Papanikolaou, this is someone you're going to glean a lot of information from, having performed over 1,000 hysteroscopies, specialist in uterine abnormalities like septate uterus, with your particular interest in blastocyst embryo culture, pre-implantation PGTA, OHSS, reproductive endoscopy, and endometrial receptivity. That's pretty much running the gambit of everything. And something that really stuck out to me on your website that I took note of was what you described as the goal of your units, which is to provide cutting-edge fertility care in an environment that supports patients' physical, emotional, and financial needs, and to make future business and clinical decisions based on what is in the best interest of the patients. You don't hear that every day, particularly in the world of fertility. So I congratulate you on that goal. I think it's very important. So would you like to give a brief introduction to people about your work and your clinics before we dive into this topic?
Thank you, Jessica, for a nice introduction. I would like also to thank all of the participants in this Q&A evening. And I'm coming from the best IVF clinic in the world that used to be the University of Brussels, the Flemish University of Brussels, that where the majority of all the innovations of IVF have been found. My Professor De Vrooy and Professor Verstategem and Professor Tournay are the most iconic figures in the IVF world. So they were the first that established ESRE 30 years ago.
As in, for anyone who doesn't know, the European Society of Human Reproduction Embryology.
The European Society, and actually it's the World Society, established back in 92, if I remember well, 87, just with 30 people in the beginning. And now in our Congress in France, there were over 12,000 participants all over the world.
Yeah, Paris, that was only a few weeks ago. Incredible, incredible.
I'm really honored that I was part of that team in the best period of their scientific career, because once I came there, already they had become very popular and enormous regarding the IVF population, more than 6,000 cycles per year, coming from all over the world, from America, Australia, United Arab Emirates, poor and rich. We were the first to start doing PGD for genetic monogenic diseases, although it's the only one that was not found in our unit. It was found in England from Professor Handyside, the pre-implantation genetic testing. Actually, we were the first that we really started working on it, and we established all the protocols for monogenic diseases that everywhere now is possible to be done. Then you had to wait more than a year to have your genetic disease analyzed and then to come to do IVF, so to test on your embryos. So you had 1 year waiting period, and all of these were almost free of money because there were a lot of research funds from the Flemish community that helped a lot the evolution of IVF and genetic testing. And I had to take the decision to come back to Greece because living abroad, you think you feel like a foreigner, or the best like a stranger. So I had to come back in Greece. And after some years, I established Assisting Nature with some partners, all of us having PhDs, and under the standards of our clinic in Brussels. So we try to make a copy-paste of our university clinic in Brussels, in Thessaloniki, in Greece. And we are happy to see that we have people not only from Greece, but all over the world that they found us not only via marketing channels, they found us via real references with patients and real cases that it's very, it's more even fruitful. So I'm here to discuss questions on a very difficult topic. What happens if I fail constantly?
Yes. So I'm so glad that you went into that detail there, because, you know, I've spoken to many other practitioners in the field. And like I said, it really stood out to me when looking at your clinic, the fact that its foundational structure is built on the research, because I love the research, as any of my clients know. And I think sometimes things get a bit lost in translation, and maybe some clinics are focusing very heavily on marketing and things that look good on the surface, but aren't necessarily grounded in the importance of the evidence. So thank you for all the work you're doing in that area. And let's dive in now to this topic. So the topic title, of course, is multiple IVF failures, what next? So we should probably start by defining, what does that mean exactly? Because for some people, like, are we putting it all into the category of it's, you know, failure at the point of retrieval? So maybe not getting any eggs or any eggs fertilizing. As I had that happen to a client the other day, she messaged me and told me that out of 17 eggs, none of them fertilized. Or is it that you're getting embryos and transferring them and it's not working out? Would you put those all into the same category?
Not at all, Jessica. So we have to make it clear that IVF failure, it means once we have more than 4 or 6 blastocyst transfer. So, and now starts the problem, because if I'm a PCO lady that I produced 17 eggs and I had 6 blastocysts, and I failed with all these 6 blastocysts, am I multiple IVF failure? Especially if I transfer them one by one. The reality that I'm not an IVF failure because I just failed in one stimulation. So maybe it's better to have the definition is that if I have more than 4 or 6 blastocysts transferred within 3 cycles, 3 stimulations.
Okay, so you'd make that distinction between all embryos collected from one cycle as opposed to spread over a few cycles.
Yes, definitely we have to take out this, because our audience, our patients, they have to realize that even if I'm less than 35, the chances to produce at least one euploid egg is only 50%. So the rest of the patients, 50% of young patients, all of them, they will have abnormal eggs. So even if they have 2 or 10 blastocysts, they will fail. They will fail. That means nothing just from one stimulation, okay? But if this is, that's where it goes, the repeated. So repeated should take also into account 2 or 3 stimulations, okay?
Yes. So that's great, just to be clear on the definition for people. And would we then go further in our definition, and would you include in that category, because there's the age category, but then there's also whether they're working with euploid embryos for transfer as opposed to non-tested embryos?
No, this is with not tested embryos.
With no testing.
So with tested embryos, there is no definition for the moment for multiple PGD IVF failures.
Okay.
But I believe that this will be the perfect definition. If I have more than 3 or 4 euploid blastocysts that especially they did not implant, then yes, I'm really a failure.
Most definitely, yes.
Without knowing the genetic status of my embryos, I don't think that the patient should get disappointed and start feeling like being a failure. So
so important to say that, because that is how people say that they feel.
Yes,
and when you explain,
I want to get this message. I want to get this message tonight. As far as my embryos are not tested, I cannot categorize myself as a failure, even if I failed 3 times. Okay, for the definition, it's okay, but the reality is that as far as I have not tested my embryos, I cannot blame my body for rejecting them or for not accepting them.
Because you're not working with the full picture of information. Not that there's anything wrong necessarily with not testing in certain cases, doing genetic testing, but absolutely, there's the two aspects. There's the embryo and then there's the internal environment.
Then,
so, go ahead.
Please continue, yes. And this is 80% is embryo, and only 20% is the environment, my hormone profile, my endocrine system, my immune system. It's only 20%. So I cannot really blame my endocrine immunology system if I don't know what kind of embryos I transfer in my uterus.
Yes.
This
so
is
on
the
that
message.
note, based on age, because we know from the research that there would be probably less utility, shall we say, for genetic testing of embryos for those who are under 35, particularly where the sperm testing is also known to be good and there's no sort of other issues. So if someone is under 35 and they've produced a number of embryos and it hasn't been working out for them, what would be the first port of call? Would you be recommending, if someone has, let's say, been through 3 or 4 transfers and it hasn't worked out, and you're talking about a 33-year-old couple, let's say, would you be recommending, even in spite of the younger age, to move to genetic testing for the next cycle? Or would you be looking internally first?
Definitely. So coming back to your age, let's say, distinction, I think that after the age of 40, if I fail, this is the normal. So because it's the normal to fail and not to have a pregnancy test right away, it doesn't mean that I will not look into my uterus with hysteroscopy, or I will not look into my microbiome, or I will not look into my thyroid if it works properly. But after 40, the status is to fail. When I'm less than 36 and I have more than 3 blastocysts, let's say, especially not implanting at all, then I have to go to more, to dig further, deeper into what might be the reason of this non-implantation. Okay, so the younger I am, and I fail more than 3 or 4 blastocysts, then it might be a point of something is getting wrong, either for the embryo or either for my environment. So definitely, coming back to your question, if I transfer more than 3 or 4 blastocysts and I'm less than 36, and I have to repeat IVF in the same IVF center or in another, definitely I will propose 100% pre-implantation genetic testing.
That's really important. And
we
on
got
that,
some questions I see here, Jessica.
Yeah, I'll be posting the questions now in just a moment. I just want to go into this in a bit more detail. So something that I think is important to raise, because I see this happening a lot.
Jessica, can you hear me?
Yes, I can hear you. Can you hear me? I can hear you.
Can you hear me, Jessica?
Yes, yeah, I can hear you. Can you not hear me? Apologies, guys.
I can't.
You can't hear me?
And now I hear you.
Now you hear me. Okay, sorry. I was just going to, before I move to the questions, which I definitely will be doing, I just wanted to clarify something there about the age and what you were saying for, doing further investigations for someone under 35. Something I've seen happen quite frequently, and it's quite disturbing, I feel, is that for those who are under 35, maybe even in their late 20s, something I see frequently happening in Ireland and the UK in particular, I'm not sure what it's like in Greece, is that people are told, oh, but it's okay because you've time. You've time on your side, and their issues are taken less seriously because they might be 31, 32, which...
It's definitely a mistake, Jessica.
Yes, absolutely agree. I just wanted to raise that for people, yes.
After the first, with the second single blastocyst transfer that fails, you should get an alarm.
Yes.
One blastocyst transfer and not being successful, of course, it means nothing, okay? But second blastocyst, especially if it's in a good looking, if it's a high-grade blastocyst, and you don't have even a biochemical pregnancy, immediately the doctor should get an alarm. So even if I have 4 more blastocysts in the fridge and I'm 30, it does not mean anything. I'm not an animal to undergo subsequent embryo transfers. We are humans. So we have always to take account also the psychology of this patient that is getting already disturbed.
Yes. I'm so delighted to hear that, because we have this issue of being told you have to try for over a year if you're under 35 before you can get help, which is nonsensical in that context. So thank you for clarifying that.
This, is bureaucratical opinion for state hospitals or etc. So
Yeah.
at least in the private clinics should not happen this.
Yes. Yeah,
Should
definitely
not happen
shouldn't.
this behavior.
So I'm going to go through some of the questions that were sent in online from some of my followers, and then I'm going to move to the chat box because I can see the questions there too, because I'm sure there's going to be many, and I want to make sure we can get through as many as we can. So the first person asked, she has an FET tomorrow after having gone through a prior miscarriage. Prednisolone, aspirin, embryo glue added. Anything else? She's wondering. Nothing had showed up in tests. Her antiphospholipid syndrome panel was fine. What are my chances? 36 years old, unexplained infertility. So for her FET...
It's her first frozen embryo transfer, correct?
She doesn't say if it's her first. It might be her first because she said it's an FET tomorrow after having had a prior pregnancy loss. So I'm not sure whether it was non-assisted conception or conception through IVF. But she's on the steroid medication, the prednisolone, aspirin, and embryo glue.
Anyhow, we know, and via ESRE we have published guidelines about the add-ons that almost none of the add-ons has been proven to work. Embryo glue definitely doesn't work. I have to say this. Yeah. Definitely, there is so much evidence. But regarding aspirin or heparin, I'm not against on this, although the chances of thrombophilia are very less, and even the tests that we do cannot exclude that I don't have thrombophilia. We have to make clear this to the patients that if undergo exam for thrombophilia and it's negative, it does not mean that we test all the known genes
that
for
exist.
Thrombophilia. Of course, it's only 60% actually. It's not even 80 or 90.
So that's just for anyone who doesn't understand with thrombophilia, with reference to blood clotting and the impact that could have on the pregnancy.
Yes. So it's the tendency to clot my blood more easily. So getting heparin, it's actually has no negative impact on the implantation. So if I have been tested for thrombophilia, it's negative, and I have already 2 miscarriages, it's not a mistake to take heparin. A lot of colleagues disagree on that, especially in England, in Holland, because they think differently. Sometimes something that is not evidence does not mean that the studies that we have we have performed are perfect.
Yes.
So when we don't have evidence for something, does not mean immediately that this is wrong. On the other hand, when I have some evidence and I continue to use embryo glue, then something is wrong.
Right. So this person doesn't have heparin noted, and there's no molecular weight heparin. It's only the aspirin that's been noted, and the prednisolone. She doesn't mention the dosage either of the prednisolone. So it's essentially the question is, what are her chances at 36 years old with unexplained infertility?
It's if she transfers one blastocyst, it's 33%. If she's transferring 2 blastocysts, the chances is 50% for ongoing pregnancy. So it's quite excellent. Regarding corticosteroids, also there is no evidence, but it seems on the studies, there are many studies that there is controversy. So when you see controversy, you don't really what really happens in the real world. So getting 8 milligrams of Drol or 10 milligrams of Prezolone, I'm giving the names also for our patients. These are pediatric doses, so they should not be afraid.
Yes. They're what I call token doses. It's low. It's not like over 15.
It's very low, Jessica, indeed. So actually they have no impact on our system, but they can tamper my immune system if in case I have a predisposition for autoimmune diseases, although I have not developed them yet. Yes, I always do use also corticosteroids, especially after 2 failures or after 2 miscarriages. Even if I have not found any autoimmune marker, but if I have found any autoimmune marker like ANA, anti-nuclear antibodies, or I have found some other antibodies, then I always use immediately corticosteroids from the first cycle, from the first transfer.
And probably from a higher dose as well.
No, the same dose.
Oh, the same.
I
Okay.
go to higher doses only if we have tested for natural killers on the endometrium, or if we have more than 3 or 4 miscarriages. Then I have to take really into consideration to give real doses then.
Yes, yes. And on that note, given what she's asking about here, because I'm sure people would ask about this, following on from what you said about what dosage you use for the steroids at what time, what then are your views on intralipids, which are often given in protocols alongside the steroids?
Yes, so intralipid is another interesting topic. I read a little bit the literature 7, 8 years ago before I started using it. So I was impressed. So actually, it's very, very safe. We give it in the intensive unit cares just for replacing the food. So actually, it's parenteral food. Okay,
Yeah,
it
has
it has lipids and calories for not dying of starving when I'm unconscious in the intensive care.
So as long
So
as somebody isn't allergic to soy or egg,
yes.
given what it contains.
So the only drawback is that it induces in some patients allergic reaction.
Yeah.
So it's wise to have our anesthesiologist present in the unit when we administer for the first time in case of an allergic shock, and not getting this in the office of my doctor. This is not correct. So I want to give you my personal opinion. The first 3 recurrent miscarriages, so I think it's only for recurrent miscarriages, not for multiple IVF failures. Okay, it's a different topic. The miscarriage, the repeated miscarriage is a different topic. The multiple IVF failures. We have to clarify this tonight.
True.
So when I give it in repeated miscarriages, my first 3 patients, they got pregnant. And they continue. So I thought that how stupid I was that I did not use it before.
Use it before.
They got pregnant and they delivered, I mean, because they used to get pregnant. The problem was the miscarriage.
Yes,
so
but it wasn't
the
continuing.
next 5 patients, none of them delivered. So after the first 8 patients, of course, I did not discontinue, but I have the feeling that I'm still using it in recurrent miscarriages. I have the feeling that should be part of the protocol. You never know if it really helps, but even if it helps 1 out of 10 of my patients, without being risky, I will give it.
And just to be clear from what you described there, that puts it in a very different category to add-ons like embryo glue, which there isn't the same. Yeah.
There isn't. In embryo glue, we have many studies. In intralipid, unfortunately, there are not so many studies. They are very small studies.
Yeah.
And you cannot judge from these studies. So my experience from recurrent miscarriage, not IVF failure, is that it's better to include it. Okay.
Yes. Yes. So I'm just going to move on to the next question here.
On the other hand, I want to say, Jessica, that once you have a repeated miscarriage or even repeated IVF failures and you have performed PGD and the patient is already 39 and she has done 4 IVF and you give everything, at the end of the day, you don't know what it really worked. It worked the PGD, it worked the cortisone, it worked the heparin, it worked the intralipid. So unfortunately, we cannot do randomized control studies with such patients, because none of them would like to
volunteer
enroll in such study, to take nothing or to take everything. So everybody will choose for everything. So unfortunately, we don't have such studies, especially after PGD. So actually, the ideal would be to do PGD and to do randomization then. One group to take aspirin, the other not. The another group to take cortisone, the other not. And some to take two and the other not. So this is a dream for all of us. But
for
unfortunately,
research, but but not for humans.
All the professors, this is the dream study, but we cannot perform it because, first of all, we don't have so many patients, and second, none of them would like to be enrolled after 4 IVF failures or 2 miscarriages.
No, they're done. They're done being
They
guinea
would
pigs.
run out of the clinic, even if everything was free.
They would. That's very true. On which note, another one of the questions here, and I know this client. So this person's gone through 6 rounds. 2 were cancelled because of cysts, and all the other rounds, no embryo made it past day 5. I'm being told low AMH and donor eggs is the only option. I've just turned 39 with prior DNA frag results last year of 33%. So should this person go for egg donation is what she's being told. But, you know, given the sperm results last year and embryos not making it past day 5. So this is the slightly different scenario. It's not multiple transfers, but the problem with getting the embryos.
So regarding this question, I before, when I'm less than 40 and I have no embryos, or you cannot exclude the role of the sperm. So every year, unfortunately, I have 2 or 3 patients that we realize that they did egg donation, but the real cause was the sperm. So the egg donation is the best biological test for the sperm. So I'm discussing with my patients, that is a crash test for husbands. Because with young donor eggs, you see if your sperm is functional. It's different to have motile or to look excellent or to do ICSI even. And it's different when you cannot make blastocysts with young donor eggs. So when I have less than 3 million of sperm and high DNA fragmentation, I propose, before we embark on egg donation, to do some natural cycle or mild IVF with hair eggs and donor sperm. So actually, I discussed with the couple to have an agreement of 3 parties. So I asked the husband, give her a good opportunity for her last eggs with donor sperm. And if it fails, then we will use your sperm with donor eggs once we will move on to egg donation. So you give something and we take back something. So I can tell you that I have 20% delivery rate just by switching the sperm before embarking on egg donation. So it's the last 10 years that I use this counseling, and really I'm glad because I save some ladies with low AMH, many IVF cycles to move to egg donation, and just because we change the sperm, and I'm really glad to say that the majority of husbands, they agree on this 3 parties agreement. So I sacrifice my sperm that looks normal for IVF, looks normal. And if we don't succeed, then we'll move to egg donation with my sperm again. And
because of course,
with the sperm, with my sperm, I have very low blastulation rate, and I fail, then the second donation will be also with sperm, with donor sperm as well, both donors.
On both, like double donation. But on that note, is there ever a situation, so before you'd move to that suggestion for a couple, of trying the eggs with donor sperm to rule out the sperm quality as a factor. Are there any other investigations you do first, such as ruling out varicocele, if there was the time available to do so, or looking for
Yes.
any infections or any issues?
All of these patients, they have undergone ultrasound for varicocele and for micro germs in their sperm and DNA fragmentation. We do also fish analysis. We do everything on the sperm. But
I only break that down because for you that's normal, but for here it isn't. That's why I said it.
yes.
So I was just clarifying it for people that in-depth investigations would be done.
We have to make it clear that at least in Greece, we perform all the tests since the patient is paying, first of all, and the tests are rational regarding the cost. So a fish test here costs only 500 euros. So why not to perform it?
Yeah.
And
versus thousands on IVF, yeah.
Because if I find 5% of them having genetic abnormal sperm, either we will do right away pre-plantation genetic testing, or we will change the sperm with donor. So this 5% of patients, they will save time and money, and of course emotions.
Yes, yes, and the emotions are key too. So I'm going to move over to the chat box, so you'll be able to see the question, which would be helpful too. So let's look at the first one here. How risky is doing PGTA on frozen embryos? I've seen this question a lot. 5 embryos frozen at 38 years old. No transfers done to date. 2 IUIs, 2 live births, which is good. Also a history of 4 miscarriages. I'm now 43. I want to do PGTA before transferring any embryos, and then lists the quality of all the embryos, or at least the aesthetic appearance of them. But my clinic in Ireland says PGTA is not reliable, risks damage to the embryos, may find mosaics, etc. Can you explain the risks of PGTA on a frozen embryo?
So first, let's clarify that we are 3 kind of clinics in the world. The one that they believe in PGTA and they do it appropriately. And once you do it appropriately, it means that you have less than 5% damage on the embryo by your embryologist, and your ongoing pregnancy rate is the same like donation. So you should have 48 to 50% ongoing pregnancy rate by transferring 1 haploid embryo. So if you have this, it means that you do it correct. And you suggest it to your patients. The other category of clinic is that they don't do it correct, and they are honest and do not suggest it. And the third category of clinics that they know that they don't do it correct because they have poor results, but they do it because they don't want to lose you from a patient.
Yeah.
So we don't know if this clinic in Ireland, they are sincere and they are telling the truth and they are afraid to do it, or they are in the last category. So
I suspect that may be what's going on from what I've seen with certain Irish clinics on this. So yeah.
Regarding now the frozen embryos, it's a different story. So the mosaic is always happening in fresh or frozen. So, and now we have very good algorithm, and we transfer almost 70% of the 50% of the mosaics with 30% ongoing pregnancy rate. So even if we find a mosaic, it's not a big deal nowadays because we
if it's a low level mosaic as opposed to high level.
So we always, not we always, 50% of them are transferable, and not even transferable. We have more than 30% ongoing pregnancy rate. So, however, when we do biopsy on a thawed embryo, then from 5%, the risk of damage because of the biopsy climbs up to 20%, 50%, depending on which is performing the biopsy. So, in this particular patient, I would suggest to do the biopsy, but she doesn't know if this center is PGD friendly or PGD experienced.
Their skill level.
So, as far if she doesn't have this information, it's better not to do it.
True, and looking at the aesthetics, so out of the 5 embryos, 4 of them had B as the first. So in other words, the inner cell mass was a B. Only one of
Yes.
them was inner cell mass of a C. Is that right? Yeah, that's correct.
Yes, yes.
Just because of the research on that showing that, slightly lower odds of getting a euploid embryo if the inner cell
The
mass
troph
is,
Yes,
yeah,
the inner
yeah,
cell mass is the most
yeah,
important, okay?
exactly. So the
And we
first
don't
letter
touch
matters
it.
the most.
The inner
Yeah.
cell mass is
Hmm.
the real initiation of the human. So what we test is the factoderm, that's the placenta
Yes.
that is coming.
Mm-hmm.
So, and this is the drawback and the advantage of PGD for the moment. You don't damage the real human, the inner cell mass, but the trophectoderm does not reflect the real human on the other hand. That's why we have mosaics.
Exactly. So the trophectoderm, which becomes the placenta, and just with mosaics, you're getting a percentage of cell damage. So euploid being less than 20%,
So,
low level, isn't it, 20 to
exactly.
50? Yeah.
So, if in the future, let's say, we find a way to test the inner cell mass without harming the embryo, there will be none in the world not doing PGD. So
Yeah.
we cannot blame PGD for the moment. It's because it's still amateuristic, let's say.
Yeah. An evolving science.
In the coming years, either with artificial intelligence or with a non-invasive PGD, I think within the next 10, 20 years, we will have an excellent non-invasive index for the quality of our embryos. But we need some time. I think within the next 10, 20 years, we will have an artificial intelligence system getting information from the culture media, okay, or even from the blastocelic fluid, or combination all of them, and we will have a real answer about the inner cell mass. And then everybody will perform only euploid, let's say, or good mosaic embryos transfer.
I hope we'll get to see it in our lifetime, because I completely agree. I think it's headed that way.
We will be here, Jessica, after 15 years.
I hope so.
And most of our patients, I hope to be pregnant, to have
I hope we'll be long
children.
pregnant and gone. I'm just going to display this question here, and thank you for that answer. That was brilliant. 6 failed transfers, 4 of them were untested, 1 euploid. I'm not sure what happened to the 6th transfer, but if we're counting those, because that would be 5. So 6 failed transfers, and certainly most of them untested. What would you be recommending to this person?
So, Katie, I think that really you start worrying a little bit because you have your first euploid not being successful. I think, Katie, you should undergo 100% hysteroscopy if you haven't so far. You should perform microbioma 100% if you haven't performed so far. And then you can discuss with your doctor about other tests. But these 2, you should undergo 100%.
And can I query there when you mentioned the testing of the microbiome? Because this is something I've talked about with my clients and looked at in the research, and I know it causes confusion for people. Would you be prioritizing the tests of the microbiome that are based from a biopsy from the endometrium as opposed to the vaginal swabs?
Definitely, only from the endometrium.
Yes.
This is
okay.
Also, I have to clarify here that ideally, we have to perform again microbiome test after the treatment that we give. So just getting a treatment and not reperforming microbiome to see if it's really changed, it's nothing. It's nothing.
Yeah.
On the other hand,
It's guesswork.
yes, on the other hand, 90% of Galactobacillus, I think is really too high. So for my patients, if they have 75
90% of lactobacillus. Is that what you're saying?
Lactobacillus,
Sorry,
lactobacillus. This is the threshold of defining a microbiome as normal.
Correct.
I think it's really high in the real life. So when I see 75% or 80%, I'm not disturbed with, and I do not
You're
say
happy
my
enough.
patients that,
Yeah.
yes.
Yeah.
So, but when I see 50 or 35%, lactobacillus, then it's really terrifying. It means something. And I have to admit here that also I did not believe so much in microbiome until recently. I had a patient from London, especially. Okay, we had 2 failed IVF with 4 blastocysts, 2 and 2, and we performed a third IVF with only 1 blastocyst failure again, and we did PGD after 3 IVF failures. Okay, because in Greece you can do PGD only once you reach 39.
Oh, I see. Okay.
Yes, unfortunately. So, or if you have more than 2 or 3 blastocysts failure before,
Failed at a younger age. Okay.
they give you then the license. So we did PGD, and she asked me for microbiome, and I was negative. You know, I don't believe in this, etc. So we did microbiome, and she has 35% lactobacillus. She took medication. We repeated the microbiome and became 75. Of course, it did not become 90%. And with the first euploid blastocyst, immediately she became pregnant. So,
and was this now with the absence of any pathogenic infections? Was it purely the lactobacillus being low, or was there the presence of any other?
There were domination, I think, from Streptococcus, if I remember well.
Okay.
There was, of course, there was another germ present, but it was amazing that with the first euploid blastocyst, she became immediately pregnant. So how can I ignore this? I cannot ignore this. But on the other hand, Jessica, when I have 70% lactobacillus, I will not gonna cry with my patient, of course. Okay, this I don't think it's too much pathological.
Yes, to stop it, as long as there isn't any really pathogenic infections in there.
Yes,
you know,
unless if you see it also in the vaginal swabs, if you see also in the vaginal swabs a kind of inflammation, then you have to reconsider. Okay.
Of course, of course. The reason I was asking for that distinction, and thank you so much for explaining that, and also what I love to see is someone being open to seeing like, oh, well, you know, I'm going to change my viewpoint now because I can see that this has actually worked for this patient, because that's what science should be, curiosity and willingness to really make the difference for people. Because I have discussed this with many clients, this issue, because there's so many different tests on the market with regard to microbiome. And I had a particular set of clients only very recently. She's now happily into her 2nd trimester of pregnancy, thank goodness. But she had one of the vaginal swab tests in the UK, and it came back clear, seemingly all healthy. But then in her clinic in Spain, they found endometritis with a biopsy. And I said, well, hang on a second, that can't be if that test were accurate. So that was treated. And on that cycle, she conceived non-assisted. Having gone through IVF, non-assisted, she got
even non-assisted
pregnant.
Yes.
Yeah, after years. So that just shows how important it is. You know,
and one reason for this, Jessica, might be the biopsy itself, because this is how the concept of scratching came in the mind of our previous professors and teachers. We performed a study 30 years ago in babuins, where they did endometrial biopsy to test the implantation window, and they were removing the uterus of these babuins later on. So what was interesting is that once they opened this uterus, they found in the majority of the babuins, the implantation site was in the scratching of the catheter for the endometrium biopsy. That's how the concept of scratching came into the mind of our teachers.
Which let's explain that to people in case people aren't sure, because an endometrial scratch is very different to embryo glue in the literature, because I know sometimes people put them into the same category. So maybe just explain a bit more about that.
I'm telling to my patients that if the inventor of embryo glue had real increasing results, now he would have a Nobel Prize. No Nobel Prize has been given to the embryo glue inventor. So let's forget it finally.
Yes. But the endometrial scratch is a yes.
I'm in favor of endometrial scratching. We have done studies, randomized and meta-analysis, and it's different to do scratching with a biopsy catheter. It's different to do biopsy via hysteroscopy. It's not at all the same. So I'm talking about scratching with endoscopic scissor in the fundus of the uterus.
The top,
in the fundus of the uterus. So this increases the pregnancy rate 10% in egg donation cycles. This is one of our original article.
Yes.
10% increase in egg donation. So from 50%, it goes to 60%.
Wow.
So I cannot ignore scratching. And as I'm telling also to my colleagues, every year, after just a simple hysteroscopy, before the transfer and a scratching, I have at least 10 patients that they got pregnant spontaneously.
Spontaneously, wow.
Because like the patient that you just referred to. So I have at least 10 patients a year that spontaneous conceive just after an hysteroscopical scratching. How can I ignore this?
No, no one could. And the mechanism of action behind it is coming from, isn't it the fact that obviously implantation is an inflammatory event?
It's an inflammation factors that they assist implantation in the coming transfers. Either if the embryo is conceived via ART or via sex.
Yes, either way. That brilliant answer. I'm going to move on to the next question here. This is quite a long one, but I want to get to everyone if I can. So after several failed day 3 embryo transfers, I'm looking into clinics in Europe, which seem to have a better success rate for people over 40. Very true. Some claim to have over 50% success rate for women with their own eggs, which my current doctor in Canada finds hard to believe. Is that number realistic? Also at 45, I know my chances are lower, but I still ovulate and I'm currently undergoing stimulation for a retrieval. What could I do to avoid another transfer failure? Life circumstances have kept me from motherhood in the past. Thank you. And that's so important to say, that life can get in the way sometimes.
Yes. So, dear Sarah, if you are 45, 50% is not unrealistic, it's completely fake if you are 45.
Yes.
If you are 40, yes, you have 40% in every cycle. So repeatedly, cumulatively, within 3 IVF, the cumulative delivery rate of a lady at 40, 41 is 50%. After 3 IVF, not 3 transfers, 3
IVF.
At 45, the chances of getting pregnant is 0.8%.
It's a big change.
Yeah. So I think you should have moved to a clinic much earlier performing blastocyst and pre-implantation genetic testing. And if you are really not stubborn, but let's say if she's really...
She wants to try,
Yes, to try.
Yeah.
Yes, you can try, but with PGTA, 100%.
Yes, 100%.
And this is another advantage of replantation genetic testing. Once I get a report that shows that my embryos are abnormal, I get more easily the decision to move to egg donation.
Yes.
Because I see it on a report, not just in the words or on the paper of during consultation.
Yes.
So, of course, Sarah, you can try at least maximum 2 more trials. That's for this 1% via pre-implantation genetic testing. And if it's all the embryos are abnormal, then you should move immediately to egg donation.
Yeah,
but being realistic, it's only less than 1% at the age of 45.
Yeah, it is definitely low odds. I have seen it. I have had clients in their mid to like 45 to 47 actually manage to get a euploid, but it's not certainly as common, you know, and it is important to rule that out. I think if anything, just for a woman to feel no regret and to feel closure before moving on, because again, going back to the mental health aspect, you want to feel like moving to egg donation is the right decision for you. And so if she can get to day 5 or day 6 blasts, definitely
And let me
PGTA.
mention, Jessica, that all these years I have only one patient becoming pregnant at 46. So the chances at 46 is 1 per 1,000. 47 is almost zero. So which are the patients that they have euploid embryos after 43? The PCO ladies.
PCOS. Those were the ones of my clients who did. Yeah.
So they take the revenge back from what they suffered all these years. So only these ladies, they can produce euploid embryo around 45. Okay, just to be sure. And I can say here that always, I have every year 1 or 2 patients that they become spontaneously pregnant with AMH of 0.01. So
if it's ovarian.
Until the last day of before menopause, you don't know if you will produce an euploid egg. But just you need a normal sexual life, of course. So for spontaneous conception, I mean. So it's the same also for IVF. So you never know, even if your AMH is 0.0 point something, you never know that if you can produce an euploid egg. But you have to believe, on the other hand, but these chances are extremely low.
Yes. Yeah. It's tough what happened to her. That
if I'm a psychological stable and economical stable, then I can try. I can chase my dream.
Yes.
On the other hand, the doctors, the reproductive specialists, we should be here to put the stop, the limits.
Draw the line in the sand.
Yes, we have to draw the line. Either the patients like it or not. The majority of them, they will respect it, that someone draw the line until when I can try. Unfortunately, in the university settings and in the state hospitals in Europe, this line is getting drawn much earlier, okay? Even because these doctors are not experienced, okay? Or they are looking into they have barriers. They are not open.
Yes.
On the other hand, on the private clinics, they promise everything, like the promised land. Because
to keep you spending.
Yes, they don't want to lose you as a patient or as a spender. So really, I can understand the patients that they don't know which one to believe.
Yes.
The university professor that he said immediately egg donation just after 2 failed IVF at the age of 42, or the private clinic that he tells you, I can put all the embryo glue of the world in the uterus at 45 and you will become pregnant. So I really pity the patients because they have to fight with 2 different opinions.
Totally.
But that's why it's my IVF answers. That's why it's the internet, the Facebook, the Instagram, to try to find which clinic is performing the truth, not the best embryological magical technique. The truth. You have to feel who is telling the truth and who is really scientific.
Yes. Yes, couldn't have said it better. Completely agree. And I wish that lady the best. Just going to display the next question here because we're close to running out of time. 4 transfers, never a positive. Only one possible 2 egg collections left. Turned 40 last week. Should I PGTA test? I only ever got 1 embryo apart from my first round where I got 2. Never had a miscarriage. I don't see the point in testing as I never had a positive. I know embryos can correct themselves and PGTA isn't 100% accurate, let's say. What should I do? No donor. If the next cycle doesn't work, that's it. So she's not going for egg donor, but I don't want to lose them if all aneuploid, as I know they will be discarded. Male factor and DNA fragmentation too is a problem. Thanks.
So I think for Karen, it's not time to move into egg donation because it's only 40, let's say. We don't know her AMH, of course. So I will completely disagree with her opinion about PGT. When the embryo is unemployed, is 90% unemployed. Regarding mosaic, we just said that we don't discard them, but we transfer 50% of them. And of course, there is a risk for the embryo depending on the embryologist that he's performing the biopsy. Unfortunately, Karen, you don't know who is experienced and who is not, and you will never find out about your clinic or other clinics. So definitely for this lady, also I will, after PGTA and all the embryos being abnormal, I might consider changing the sperm. So if it was a severe malfactor and DNA fragmentation more than 50%, I will in the concept of the three parties agreement that I discussed just earlier with you, I will consider not this time, but after an abnormal PGT test, then I will consider donor sperm before I move to egg donation.
Yeah, I think that's key, and especially given she was quite clear on not wanting to move to egg donation. So if this is it, if this is your last 1 or 2 cycles, well, then it's worth throwing everything at it. And obviously, if PGTA is done,
if Karen can know how many PGT friendly is this clinic, if they perform a lot of PGT, let's say more than 100 cycles a year, then normally should be experience, okay? Because the hand become experienced. It means that we have PGT almost every day if we have more than 100 a year.
Yes.
So I think she's wrong. She should believe on PGTA.
I think it's more maybe to play devil's advocate where she's coming from, having seen some of these suggestions in the literature. You know, when you see that one story of, oh, you know, an aneuploid embryo transferred and it actually resulted in a healthy pregnancy. But I think it's important to state that that is infrequent. That is very rare. It's not the norm.
It's a case report. It's a case report.
Exactly. So definitely don't feel that you'd be not giving those embryos a chance. You're giving yourself a better chance and minding your sanity by knowing the quality of the embryo.
On the other hand, she can transfer an haploid embryo. So once in every 5 years.
Oh, where did he go? Oh, that's well, hopefully he'll join us back, because I was really thoroughly enjoying that conversation with the professor. So hopefully he'll be able to join back in the link. And I'm just looking at the questions here, because we've 2 minutes left. We're kind of running low on time. And I'm looking through the questions here. We've another, few to go. So I'll just see now if Professor Papanikolaou can join us again. Let me just check with the tech team here. Bear with me, guys. There's always something. Last time we had issues with sound. So let me just check. Ah, there you are. Wonderful. I can't hear you. Just check. There you are. Oh, perfect. Okay. Don't worry. Don't worry. It was only a moment. So sorry, you were making a point there about the PGTA and the mosaics for that woman.
I said that I had once every 3, 4, 5 years, I have a patient that she's telling me that I want to get transferred my unemployed embryos. So you don't risk to lose this. So if you don't believe so much in the science, do the test.
Yeah.
If it's all of them abnormal, give them a try. And if then you have DNC for trisomy, you will know that you have done wrong.
Yes. Yeah. So in other words, if the person conceived, miscarried, and then they did the cytogenetic testing on the tissues and you could see there was a problem, then you know that was the issue. But correct, she could try, but it certainly makes sense to do the PGTA first.
Of course, Karen, she raised, and maybe you, a point that all the genetic labs are not perfect.
No.
Because they undergo ISO control does not mean that they have a perfect genetic testing, okay? So we know this. There are reports in literature, especially from the States, that a huge, if in the States we have such variations in the genetic reporting, you can imagine what might happen in other countries.
Very much so. Yeah.
So always there is a possibility that the genetic lab is not perfect, although they have an ISO quality control system. But if we start thinking like this, we will never trust anything in science.
True. Very true. We're doing the best with what we've got. Now I'll finish on this question because we're literally going a minute over, but just because you brought it up earlier, and I think it's important, what are the full set of tests for sperm quality? Because this is something that is really miscommunicated to people a lot, particularly in Ireland, as people are told that they only need a semen analysis. So can you expand on that a bit for people?
No, of course, Andrea, the full sperm, let's say, tests are sperm analysis, oxidative stress analysis, DNA fragmentation. For me, it's really very important,
Yes,
and
me
fish.
too.
And
And the
fish.
fish.
Fish is karyotype on the sperm. Okay.
Yeah.
Actually,
Counting the trisomies like fluorescence in situ. Yeah.
Karyotype on 500 spermatozoa, and to see how many of them are abnormal.
Yeah.
These
So
are
there
the
you go.
These are the 4 tests for the sperm.
And to go further, because I know this will be the next question, just to finish on this, if there's deviations there, what would be the next set of investigations you'd go to for figuring out what could be impacting the sperm?
So if we have a genetic abnormality, then 100% we should do PGT, irrespective of the age of the lady. If we have a FISH positive result, that is quite rare, but it happens. And regarding DNA fragmentation, I think the answer is very easy, irrespective of the treatment, because actually we give vitamins, we don't treat the DNA fragmentation. So it's stupid. My husband continues smoking, and on the other day take expensive vitamins.
Yeah. So true.
So
And alcohol.
And alcohol. And working in I don't know, working in a factory.
Yeah, surrounded by chemicals. Yeah.
So in this scenario, if my DNA fragmentation has not decreased, then we perform PIXI or Zymote. It's not so
Sperm
expensive.
selection techniques.
So we do an extra selection of the sperm, not only on the microscope, or PIXI, it's higher magnification. So we select the morphology, and Zymote is a test for deselecting the fragmented spermatozoa.
So you can pick the best sperm from a bad batch, basically. So you have better chances of success.
At least not fragmented.
Yes.
So there is a solution. There is a solution.
There is. And I can't tell you how glad I am to hear you say that and going into the description about the tests, because for anybody watching from Ireland, as they probably know, there are quite a number of clinics here who take a strong stance on saying that sperm DNA doesn't matter. And just there is so much in the literature to counter that viewpoint. So exactly as the professor said, please make sure that you are doing the due diligence with where you're getting your information from and making sure that they actually back it up with the evidence, which is why I so enjoyed this conversation this evening. It was an absolute pleasure. I'm so sorry that I couldn't get to all the questions, or sorry that I couldn't give the professor all the questions, but where can people reach you after this if they want to contact your clinic or are interested in treatment?
We're more than glad to receive and answer these questions. Also, Jessica, you are an excellent co-hosting.
Thank you so much. Well, I think I love this topic as much as you do. So if I'm ever over in Greece, I will definitely get in contact to go to a coffee for a very long chat.
It will be our pleasure.
So thank you, everyone. As Professor Papanikolaou was saying, you can contact him at Assisting Nature. Is that right? Is there an email address people should use?
Yes.
What's the email?
info@assistingnature.gr.
GR for Greece. So info@assistingnature.gr. And for myself, as you probably already know, as a fertility detective, you can contact me on Instagram. I'm always doing quick voice notes to people whenever I can to try and help guide you. Always non-biased, independent advice, because I know how tricky this journey is. And if you can come across someone like Professor Papanikolaou, you are doing well. So definitely make sure to do your research and go with something that makes logical sense. So thank you so much. That was an absolute pleasure. I look forward to speaking with you again. And thank you all for submitting your questions. I hope everybody has a great evening. Thank you.
Bye-bye to all of you.
Take care.